So thank you everyone for having me today, and it was really great to be sitting at the back and hearing a lot of your questions. I think a few of you can come up and do my presentation for me if you'd like. So it's really great to hear that people have so much information already, but very happy to answer any questions, and I think I might answer a couple of the questions that came up in what I'm about to say as well. So hopefully we cover some of those things too. If what I'm saying doesn't make sense, please tell me. I'd hate for you to sit here and listen to the whole thing and have no idea what I'm saying. So if it doesn't make sense, just put up your hand and say, can you explain that? Okay. So Anne's covered a lot of these things, but I guess wanted to make a disclaimer right at the beginning that ovarian cancer is a really broad area. So what we're talking about most of the time is the most common form of ovarian cancer, which is high-grade serous or serous papillary ovarian cancer. But there are lots of other rarer types, and so most of the treatments that we talk about here might not apply to all of those rarer types. And if you've not been offered those things or they don't seem to apply to you, it might be because it's a different type. And ovarian cancer sort of is used to cover the overall sort of it's the overall label that's given to cancer from the ovaries, or the fallopian tubes that link the uterus to the ovaries, or the lining of the abdominal cavity, which is the peritoneum. So I'm mainly going to talk about, in the first instance, about targeted therapy and immune checkpoint therapy, or immunotherapy, as you said. Anne's talked through chemotherapy fantastically, also intraperitoneal chemotherapy, and I'm not going to talk about radiotherapy or surgery either. I just put one slide in to say that although I'm not labouring the point, ovarian cancer is really very sensitive to chemotherapy, and we actually see a response in most women who have it first up. So it's actually the foundation of our treatment for ovarian cancer, at least in the first instance. And there's a good reason why it works, or why the carboplatin works. I will explain that when I talk about PARP inhibitors in a minute. So I hope that this analogy makes sense, but you see the spiral of DNA, and you often see that sort of picture of DNA. If you can imagine, take this sort of away from the DNA for a minute, and imagine you unwind that spiral and it's straight and it looks like a ladder. Okay, you've got two long bits and the connecting bridges. Take that a little step further and imagine it's made of Lego blocks. If you take a few of those Lego blocks out, you'll weaken your ladder, but it'll stay together. If you take too many blocks out, the ladder's going to fall apart. So PARP is an enzyme, or is a particular thing in the blood that helps us repair our DNA. So that's putting the blocks of Lego back into our ladder. Okay? If we're blocking that enzyme from working, the PARP, then the ladder doesn't get repaired, and our DNA is being damaged all the time. So if the DNA is being repaired like normal and the blocks are getting put back, our ladder stays strong and our DNA stays stable, and our cells can replicate, and the cancer can replicate. If we stop the repair happening with the PARP inhibitor medication, then the ladder falls apart and the cells can't keep turning over. And that's how PARP inhibitors work. It's actually also how carboplatin works, more or less. So there's a good reason why the chemotherapy works, and there's a really good reason why PARP inhibitors work. And they're actually really clever medications targeting that specific DNA repair process. So Olaparib is the only one that's approved in Australia at this point, and that's for germline BRCA mutations. It is accessible for somatic BRCA, women who've got somatic BRCA mutations, and we'll talk about that in a little while as well. You might have been part of clinical trials that used some of the other PARP inhibitors, Rucaparib, Niraparib or Pamiparib, but they're not PBS funded or TGA approved in Australia at this point. So this is, and this was a little bit of the discussion from earlier as well, this is sort of the timeline of Olaparib. So there was a small study back that was published in 2012 that showed overall a small but obvious benefit of a PARP inhibitor given after chemotherapy when the cancer had shown that it was sensitive. So the cancer had shrunk in response to the chemotherapy. Then women were given the maintenance PARP inhibitor, so given a tablet ongoingly, and it showed that more women, it's a small number of women had a longer time to their cancer returning. 2 years later, they went back and looked at the data that they had from the trial originally, and they looked at it by virtue of the presence or absence of the BRCA mutation. And they saw that the benefit was actually much more and really quite impressive in the women who had a BRCA mutation. And the women who didn't have a BRCA mutation did seem to benefit a little bit, but not sort of as significantly. In 2016, they had, by that time, then run another trial, and they had shown that this was in fact the case, that women with a BRCA mutation clearly had a better outcome if they'd had a maintenance PARP inhibitor. At that point, it was showing that the time to relapse was longer, but survival wasn't mature. And there are lots of reasons why it's hard to show that people live longer in a clinical trial, because they keep getting treatments after that. So it's a little bit hard to show that. But in 2016, the PBS advised that they would approve Olaparib for women who had relapsed ovarian cancer and a germline BRCA mutation and then responded to their second-line chemotherapy. And in 2017, that was then available to women via the PBS. So this was a study that was published at the end of last year. You don't need to understand all of the details, but this was actually looking at moving that PARP inhibitor to the first-line setting. So if it works when the cancers come back, why wouldn't it work if we move it earlier? So this is actually using it in women who have advanced ovarian cancer, they've responded to chemotherapy and have a BRCA mutation, and then they use a PARP inhibitor straight after that chemotherapy. And so this is a really impressive result. Like this is one of the most amazing things that we've seen in ovarian cancer research for many years. There's kind of a saying in medical oncology that you see the blue line and the red line, and the blue line is the women who got Olaparib and the red line is the women who didn't get Olaparib. And if you can drive a truck through the two lines, then it's worth having. And so this is a drive a truck through the two lines kind of graph. So this is a really good result. And this was around 3 years that the cancer actually came back later. So that's really meaningful results.
Was that work done here?
I think Australia was involved in Solo 1, but it's a trial run across the world. And that for women with a germline BRCA mutation or a blood, familial genetic mutation is available, and it is available for women with somatic mutations as well. That's the tissue in your cancer. The other targeted therapy obviously is Avastin or bevacizumab, and Anne's talked about how that works. The cancer needs blood supply to feed and to grow. It needs those nutrients and oxygen and all of those things. So if you prevent the formation of blood vessels, the cancer can't keep growing, and that's really how it stops the cancer growing. We give it with standard chemotherapy, the carboplatin and paclitaxel, in women with stage 3 and 4 disease. And the questions about whether it should or shouldn't be given that were being asked, the answer to that is that in those women with later stage disease, the trials showed that the cancer didn't come back as quickly, but it couldn't show that people actually lived for longer, and it's actually quite short. So there is a benefit, and some people do very well using Avastin, but the benefit is a little bit equivocal, and you'll get a different opinion from different people as to whether it's a meaningful benefit or not. So when people have problems, when it's started, and then people have problems on it, it's, I guess, less concerning if we have to stop it for a reason, because we know that the bulk of the work's being done by the chemotherapy and various other treatments. There was a question earlier about immunotherapy or immune checkpoint therapy. These are drugs like PD-1 inhibitors. You might have heard of Keytruda or pembrolizumab. It has a big role in melanoma. CTLA-4 inhibitors, and you might have heard of Yervoy. And these work by blocking some of the inhibitory or the negative signals in the signalling with our defence cells or our white blood cells within that sort of surround the tumour. And so it essentially upregulates our body's own immune system to fight the cancer. That works very well in some cancers, more immunogenic cancers, and less well in others. And because it works quite differently to chemotherapy, and it's not just killing cells as such, the side effects are also very different. So they relate to almost autoimmune side effects where the body is actually attacking the cancer but attacking our normal cells as well. And despite good results in other cancers, it's really yet to find a place for treatment in ovarian cancer. It might be that it works well in a specific subtype of immunogenic ovarian cancer, but that particular testing is still more of a research test rather than a widespread test. And by itself, it in sort of later line studies, and we don't really have studies yet of it being used up front, but later line studies suggest that maybe it only shrinks the cancer for about 1 in 10 women. It might keep things stable, but actually getting shrinkage of the cancer has been a bit less exciting, I suppose. So there are lots of trials running at the moment using it in combination, and there is some pretty interesting, at least, maybe not exciting yet, but interesting signal that working with drugs like bevacizumab and sort of low-dose chemotherapy drugs, that maybe we can actually get a better response, but maybe it's just not very helpful by itself at this point. So I was asked to talk a bit about drug approval and what this actually means. So there's been a little bit of talk about the PBS already, but the first hurdle, I suppose, to getting a drug into Australia is the Therapeutic Goods Administration. And that means that they are the body that would approve a drug to be used for a particular reason within Australia. So for a particular disease or kind of cancer. That means that there needs to be enough data that it's safe to use and that there is some evidence that it actually works. The Pharmaceutical Benefits Scheme is the area of the Department of Health that agrees that they will actually fund the cost of that drug. So it's quite different to be approved by the TGA, which just means that it's allowed to be used in Australia, and to actually have been decided by the Pharmaceutical Advisory Committee that they're actually going to fund that drug. And they, need to know that it is effective and it's a good treatment. They need to know that it's safe, and they also look at the cost-benefit analysis, and there are obviously various ways that they do those things. Other means of drug access include pharmaceutical company schemes. So this is access provided by the pharmaceutical company before the PBS, and sometimes even before the TGA have approved it in Australia. And this is good because it enables access for patients to beneficial drugs that haven't sort of caught up with the whole process yet. The pharmaceutical companies, I guess, sometimes like to do it because it improves doctor familiarity and it increases awareness generally of the drug, and there is more sort of impetus to get it approved in Australia or whatever country. But because it's actually not approved by the TGA, there are lots of extra levels of agreements to say who's responsible, that there's awareness that this isn't approved in Australia, and so there's sort of a lot of documentation and things that need to go along with that. But it can be a really good way to get access to drugs where there is no other sort of governmental way of doing so. And then there are cost share programs, and so these are where the pharmaceutical company might have sort of a structured scheme where they someone can fund a medication themselves that there's no access to otherwise, but with a capped cost. So there might be a certain dollar figure that they will pay after that, so the patient has to pay up until that point, and then they'll keep funding it provided that the drug's working. Sometimes it will be that the patient will pay for one dose, and then the company will pay for doses 2 and 3. Patient will pay for dose 4, and so forth. And there are some instances where the testing for particular mutations is not funded, but if someone pays for that themselves, then the drug is actually given free of charge. And so the example there is Olaparib, where the testing for a tissue or a somatic mutation is not funded by the government at this point. But if you have that testing done either by a commercial assay or through the company, and you actually have a tissue BRCA mutation, then they will give the medication free of charge. Compassionate access is kind of the name given to the very rare cases, and this often relates to rare cancers, where there isn't a standard pathway to drug access, but a very good reason, a scientific reason to think that it would be effective. And so the doctor might make a case to the company directly, sort of essentially petitioning them to give access to the drug. And that might be fully paid for and at no cost, or it might be partly subsidised. So where clinical trials are heading, I first just wanted to run through sort of why clinical trials are run and what they're actually about. And the reason to run the trials, sort of broadly speaking, is to fairly test the drug to see if it's better than what we're already doing, because we don't want to use new treatments because they're new, we want to use new treatments because they're better. So we need to actually prove that they're better than what we're already doing. For the drug company, it helps them to prove that their drug works better than standard treatment and get it into clinical practice. But for the patients and the doctors, then it helps us to get access to treatment which we think is better than the standard treatment. In some cases, a clinical trial will run and they'll actually find that it wasn't better than the standard treatment and that drug wouldn't go ahead. But in most cases, there is enough evidence by the time it's in a clinical trial, certainly later phase clinical trials, that it's probably superior to what we're already doing, and so it might give you an extra sort of treatment option. There are different phases of clinical trials, and this can be a little bit confusing. Obviously, there are studies done in the laboratory before a drug ever gets to being used in people, and there are animal studies that come before that as well. But I've worked backwards there. Phase 3 trials are the latest stage of clinical trials, and that's where the drugs have already been tested in smaller numbers of patients, and they need to be tested against our true gold standard to actually show that they're effective. And a phase 3 trial is what would usually get a drug onto the PBS and get it approved in various countries. Phase 2 trials are a little bit smaller, and that's when the drugs have already been shown to be safe, to actually look for effectiveness and further sort of safety data and things like that. And phase 1 trials are quite different. These are very early drugs. They might have been only tested in animals if they're a single agent drug, or in just very small numbers of people, or the combination might not have been used in that way before. And so they are quite a different clinical trial to be part of. There might be a good scientific reason why we think it would work, but it's certainly not as much of a guarantee, I suppose, that it would be an effective treatment. So it's often a place, or something that people will think about later down the track, where there aren't as many options. But there is quite a big difference in actually participating in a phase 1 trial. And there's a lot of contact with the hospital. It's quite intensive, and there is extra blood tests and things like that. And so it's not always for everyone. And it's something that, if it's brought up as an option for your care, it's really good to talk to the doctors who are running that trial in your particular hospital or wherever it's being run, and ask them exactly what's involved in actually being part of it, because it is quite different to a standard clinical trial. So some of the trials that are running at the moment, and this is by no means an exhaustive list, But this gives you an idea. These are some of the bigger trials, and this gives you an idea, I guess, of where the science is heading. And you'll see that a lot of these include immunotherapy in combinations, and there's quite a lot of trials using PARP inhibitors. So there's kind of the big things, I suppose, at the moment. So iPrime is a clinical trial using 2 immunotherapy drugs, durvalumab and tremelimumab, with our normal chemotherapy, carboplatin and paclitaxel, before surgery for women with stage 3 and 4 ovarian cancer. And that would then continue thereafter as well. Imagine is a clinical trial using our standard chemotherapy of carboplatin and paclitaxel with bevacizumab, and then adding atezolizumab, which is an immune therapy drug. They've all got long and terrible names, and you don't have to remember any of them, but you can just know that that's essentially adding an immune therapy drug to our normal or standard treatment for the primary treatment of either women who've got stage 4 disease and might not be having an operation, or who haven't had a complete operation, that R0 resection that was talked about earlier on. These 2 are clinical trials using PARP inhibitors, both Olaparib. ICON 9 is a trial using Olaparib plus or minus cedarinib is kind of an oral form of bevacizumab. So both given as tablets, and it's using both of these as a maintenance treatment after relapsed ovarian cancer. So in the same way that Olaparib was originally studied. You don't need to have a BRCA mutation to be part of that clinical trial. So I wonder if that's what you ladies were talking about earlier on. Yep. Solus 2 is a trial using Olaparib with a low-dose oral chemotherapy medication called cyclophosphamide, followed by Olaparib plus or minus an immune therapy. It's a very complicated trial in women who have a rising CA125 tumour marker, but no actual disease seen on the CT scan, and a DNA repair deficiency genetic modification. So that might be sort of other DNA repair deficiencies that are like BRCA but not actually BRCA. There are some phase 1 clinical trials. One of these is just finished up, I think. But these are looking mostly at combination treatments, so a PARP inhibitor and an immune therapy drug, a PARP inhibitor or a chemotherapy drug, and another one that's Rucaparib, so not our the one we're more familiar with in Australia, but similar PARP inhibitor with an immune therapy drug. I wanted to highlight these because these are really interesting clinical trials. When we say translational clinical trials, it means that we're trying to bring what we understand about resistance and why treatments don't work or why they do work from the laboratory and actually bring that into the clinic. So PRECISE is a trial of Pamiparib, which is another PARP inhibitor, in women who have become resistant to carboplatin or other PARP inhibitors, usually Olaparib, because the gene that actually pumps the chemotherapy agents or the Olaparib agent out of the cells has upregulated itself and evolved to get around the chemotherapy. So it's really, one, it's very clever that the cancer can do that. Secondly, it's amazing that we've been able to work out this way of potentially getting around that. So this is opening in a couple of months at Peter Mac, and it's a really interesting clinical trial. We're pretty interested to see what the results of that are. Beacon is another trial which is using immune therapy, bevacizumab and chemotherapy in women with a particularly resistant kind of ovarian cancer, and there are various scientific reasons why we think combining those will actually bring the immune cells into the cancer and help them to fight it, rather than having them sit outside in sort of the stroma that sits around the cancer itself and not being able to get in to do what it needs to do. Just a brief mention about rare cancers. It's often quite difficult if you have a rare cancer or you've got a family member who has a rare cancer, because you tend to get excluded from clinical trials, and this is actually a real disadvantage when you're looking for that as a treatment option. There is a rare cancers trial running at Olivia Newton-John at the moment as the primary site, but running at lots of different sites. And there is a rare gynecological cancers arm, so some of those rarer ovarian cancer subtypes would fit that into that category. And it's using ipilimumab and nivolumab, which are both immunotherapy drugs. And so that's been a really exciting trial that's still going at the moment. We don't have results of that as yet. So I wanted to talk a little bit about the use of PARP inhibitors for women without BRCA mutations, because obviously there's a lot of evidence now that they're effective for women who do have them and a reason why they work. But they do still seem to have some activity, even if that germline BRCA mutation isn't there. And so I think someone's talking about genetic testing later on, and they might explain some of these things, but just briefly, BRCA1 and 2 are normal tumour suppressor genes. And that means they're actually a good thing when they're working properly. They're meant to help repair our DNA and help suppress the damage that's done to our DNA over time and with age. But mutations in the gene means that our body's cell repair pathways don't work properly. So although obviously women with BRCA mutations are the most sensitive to PARP inhibition, we still see, and you'll remember from the very first Olaparib study that I mentioned, they actually still saw a benefit in the overall, so the all-comers group. It was just less. So there are some reasons why this would be the case. And we know that, in fact, up to 50% of ovarian cancers, the cancers themselves, will have another DNA repair deficiency problem. It might not be BRCA itself, or it might be a tissue or a somatic BRCA mutation that we don't identify on a blood test. But BRCA is just one part of a long pathway of genes that are involved in our DNA repair, and certainly BRCA is the most important of those, but there are lots of spots along that pathway that can have mutations that mean that a PARP inhibitor can still work. The other answer is that for people who we can't find any of those things, one, maybe we don't understand the science well enough at this point, or that targeting DNA repair still works a little bit, even if the DNA repair mechanism is normal. So if you've got your Lego ladder, if you poke out a few of the blocks, you're still doing a bit of damage, and so you're still probably slowing it down a little bit, even if it's not stopping it as well as it did if the DNA was already shaky because of the BRCA mutation. This is once again a bit of a scary slide, so you don't have to understand the details. But this was Ariel 3, a trial using Olaparib, one of the PARP inhibitors. And the reason I've put it here is to show you, or to illustrate the point that in graph A, that's women who received a PARP inhibitor as a maintenance treatment who had a BRCA mutation. And all you need to sort of look at is, I guess, how far or how wide the lines are apart. So you can see that in the A graph, there's actually the widest amount of space between the two lines. B is the women who didn't have a BRCA mutation but had other reasons for DNA repair problems. One of those less common or sort of lower downstream DNA repair problems. And then group C is actually the all-comers. And so you can see that there was a clear difference between those two groups, even when people didn't have any reason for DNA repair problems that we could find. The top graph translates to about 11 months difference between a placebo and the PARP inhibitor, and graph C, the all-comers, had their cancer not relapse for about 5 months more than the placebo group. So it's still meaningful if that was a tolerable medication and it was actually not, certainly as a maintenance treatment, we don't want people to be having ongoing terrible side effects because it's not meant to ruin your life as a maintenance treatment. But if it was tolerable, 5 months is very meaningful to not have the cancer come back and be living well and not on other treatments in the next line of chemotherapy. This is just a brief mention about another trial that's actually looking at this particular setting, although not using Olaparib as a maintenance treatment, but actually using it as treatment for relapsed ovarian cancer with DNA repair deficiencies, but not the germline BRCA mutation. So we don't have all of the information about that as yet. The big clinical trials have tended to exclude that wider group. The Olaparib data has been very good in that they've included that other group of sort of DNA repair mechanisms, whereas the Olaparib data has really focused just on the germline and a little bit on the somatic mutations. So we're waiting for lots more information about that, but I think over the coming years we'll understand a lot more about all of this. And lastly, I was asked to talk a little bit about progress on prevention. And this is a bit of a hard area to talk about because the short answer is we haven't made very much progress. But as you know, there's no formal screening test that's proven to diagnose ovarian cancer earlier and to prevent incurable disease, at least in women who don't have a BRCA mutation, who aren't having formal screening through their familial cancer centre. And as Anne mentioned, that if we can diagnose ovarian cancer earlier, the outcomes are markedly better, and unfortunately, because there are so little symptoms, often the diagnosis comes at a much later stage. The problem is that a screening test has to correctly identify women who truly do have ovarian cancer, but not identify women who don't have ovarian cancer. So if we have a high false positive rate, it means that a large group of women will go on to have further investigations, sometimes a laparoscopy, which comes with its own risks, and in the worst case scenario, life-threatening risks, and experience worry and anxiety about this diagnosis when they don't actually have ovarian cancer. And certainly it's a good outcome if they don't have it, but to go through all of that and be putting lots of people through that is not really a very effective screening program. So the combinations that have been tried are using the CA125 tumour marker or other tumour markers, which are less widely used at this point, ultrasounds and CT, and no study at this point has been able to show that we can convincingly and accurately identify the group of women who do have early ovarian cancer. The part of the problem is that the CA125 can be raised for lots of reasons, and these can be endometriosis, other reasons for ascites or fluid buildup in the abdomen, such as cirrhosis or liver disease. Smoking can increase your CA125 level. Different ethnic groups will have a slightly different CA125. Pelvic inflammatory disease or other cancers can also cause an elevated tumour marker test. You've probably already heard about this, and I noticed it on the posters outside, but I think that in terms of progress on prevention, this is actually one of the best things that has happened in a little while. So Traceback is a project that aims to identify women who missed the introduction of the mainstream genetic testing, which has been funded since November of 2017. So most people who come through or are newly diagnosed now would, I hope everyone, is offered genetic testing. This aims to go back and find those people who missed out on that, if they're still alive, to offer them testing themselves, and that may or may not change their treatment options, but it will also have the obvious implications for their family members. If the women have passed on since their diagnosis and since that they were being treated, their relatives will be contacted for testing. Contacted to ask if they would be comfortable with the idea of pursuing testing and actually identifying whether their family does carry a BRCA mutation, which has the implications for the rest of their family, so they can get the appropriate counselling through a familial cancer centre and also the appropriate screening for the relevant cancers, and obviously not just ovarian cancer.